Good evening, everyone. Um, I'm Dr. Amar Lal, hematologist oncologist, Tamam Hospital, Alain, UAE. Thank you for inviting me to talk on sustained remission in patient with ITP after romiplastin tapering and discontinuation. No disclosure. And next 20 minutes in the context of talk of remission in ITP after romiplastin tapering and discontinuation, I will go through 7 steps of eye opener D8 of ITP. D8 means definition, demographic, disease process, and disease dilemma. What is the initiative and goal of ITP? ITP journey from A to G, advantage of romiplastin, and real world experience, and finally. So eye opener. What color is ribbon for ITP? Just keep in mind, check your test. It is purple. D1, define. How you define ITP? ITP is defined either by association or by chronicity. By association, if there is no association, we call it a primary ITP. No association of the disease. Platelet count is less than 100,000 and more than 80% we see this type of ITP. Secondary ITP, if you have any association of the disease, like immune disease, SLE, RA, and other things, infective disease like HCV, HIV, and H. pylori, and infiltrative disease like lymphoproliferative disorder. Then by chronicity, 0 to 3 month, newly diagnosed, 3 to 12 months, we call it a persistent ITP. After 12 months, we call as a chronic ITP. D2, demographic. The demographic here, you can see it starts from younger age to older age and equally distributed in both genders. D3, diagnosis. Diagnosis step is same, first history physical, then peripheral smears, and then you check infective process, HCV, HBV, HIV, and H. pylori. And then in useful in circumstances, you do antibodies like ANA and antithyroid antibodies, and you see some PCR parvovirus. Unproven benefit is thrombopoietin level, bleeding time, and serum complement. D4, diagnostic key. Peripheral phlegm is actually diagnostic key, which can compare it is really thrombocytopenia. If it's really thrombocytopenia, you have to collect blood sample in heparinized syringe. Then if you see these type of the cells like large platelet seen, which is seen in the ITP, and it can be seen other diseases as well as Bernard-Sery syndrome and other diseases as well, but most common is the ITP. D5, diagnostic antibodies. Actually, there is no reliable test to confirm the ITP. However, they try to check the platelets and autoantibodies as evidenced by the meta-analysis study published in 2019, which revealed that direct testing is about 53% sensitivity and 93% specificity, and indirect testing is 18% sensitivity and 96%. So sensitivity is very low, but specificity is very high. It is very specific test. However, ASH doesn't recommend to use platelets antibody testing for the diagnosis of ITP as a 2020. Treatment dilemma. Dilemma starts from 1900 with the splenectomy, followed by roids, then IVIG, then anti-DNA, then rituximab. Now the era of TPO mimetics. GSEMA, initial management of treatment. What are goal of the ITP treatment? Does this patient require treatment for ITP? Should this patient be admitted to the hospital? We'll go each by the guideline. So what are initiative? When and what to initiate? What is the goal of ITP? Goal is very clear. If bleeding, stop bleeding. If not bleeding, prevent bleeding. But specify to the patient condition. Preference to patient condition, lifestyle of patient condition, risk of the bleeding patient condition. So based on this is an ASH guideline. The goal of treatment is not to raise platelets count to normal level, but to reduce the bleeding, even lower level up to 50,000. What ASH guideline recommend? ASH guideline recommend if platelets count is more than 30,000 and patient is asymptomatic, please leave the patient alone. No treatment. Observation, unless there is comorbidity or patient taking aspirin or something, age is plus 60, then you think over it. Otherwise, 30,000, fair enough. Now, if patient is less than 30,000, start treatment with the steroid, but don't admit. But if patient has platelets less than 20,000 and patient is bleeding, so admit the patient. If more than 20,000, don't admit outside outpatient management. Important here, Pearl, is please keep in mind, avoid non-steroid anti-inflammatory drugs, and patient is with anticoagulation, just keep an eye. So initial treatment, we have two choices, prednisolone and dexamethasone. Prednisolone dose in 1 mg per kilo per day over 2 to 4 weeks, then taper within the 6 weeks. Dexamethasone is high dose, 40 milligram, day 1 to day 4, and you can repeat 1 to 2 cycles. Both are actually same efficacy, but dexamethasone is rapid response and less side effects. So people sometimes prefer the dexamethasone over the prednisolone. Otherwise, they are good both. Now, additional treatment if you need with the steroid. There are two other options which call a rapid response with the IVIG. If you give IVIG, it's called rapid response, especially the patients who are bleeding or admitted. How it works, IVIG? So this is IVIG. If you give IVIG, what happens? They attach to the Fc receptor of the macrophage in the spleen. So all these receptor is occupied. Now the platelets, which is covered by R2 antibodies coming, so there is no place for this platelets R2 antibodies. So no platelets destruction. So no phenomena of ITP. So it start by IVIG. How anti-DNA works? Anti-DNA, it works in Rh positive blood groups. So this is suppose Rh positive D antigen, and you give anti-DNA, it's attached to the RBC. So what this happen, RHA, this RBC and antibody, they attach to the receptor in the macrophage. So all the receptor is occupied by this one. So there is no place for the platelets coated R2 antibodies. So platelets are not destroyed. So this is how it prevents by phenomena of ITP bleeding. Now other option is upfront rituximab. There is one trial published in 2010. They have seen there is better, you can say, sustained response is statistically significant. So you can use in some circumstances aid the rituximab. And some people also use MMF. And there is data that MMF with dexamethasone is better response as compared to the dexamethasone. So some people also refer, but again, this is not an ASH guideline. So now, how to define response? CR means more than 100,000 platelets count, or response is like more than 30,000 platelets, or twofold increase the baseline. What about the spontaneous remission with the steroid? The spontaneous remission, there is no clear data. It's different from somewhere between 10 to 25% they have seen spontaneous remission, who are lucky enough. Summary. Steroid remains the preferred initial therapy. Both spontaneous and steroid-induced remission is uncommon in adult. Suggested data use of rituximab or TPO agonist initial therapy to improve the ITP remission. It's in the process. It may emerge later. Now test whatever we have done now so far. This is one patient, 39-year female. She just checked routinely. Her platelets count only 100,000. And this is isolated thrombocytopenia. She checked over the 4 years, same platelets counts. She had history of easy bruise. She had history of heavy menses. So what do you think in this patient? You will do so many tests, ANA, lupus and everything? No. What you learn from here, diagnostic key is peripheral phlegm. You will just check peripheral phlegm. It is compatible with ITP, just follow the patient. Now, what you do about the treatment? Rechecking your first phenomena. 32-year male, female, thrombocytopenia, 45,000. Otherwise, she's fine. Confirmed ITP by peripheral smear and other tests. So what do you do? 45, asymptomatic. You will not do anything. You will observe, as you have mentioned, 30,000 plus, you will not do anything. Now, option for second line treatment. So we have three types of treatment: TPO agonist, rituximab, and fostamatinib. These are mechanism of that. So first one is TPO agonist. 1 decade ago, actually, TPO agonist came, effective second line. It has shown up to 90% effective. And it's so robust and rapid response, it affects 1 to 2 weeks. And some patients also discontinue therapy up to 30%. And so nowadays, we are using also before surgical procedure, the TPO agonist. So we have 3 TPO agonists. The interesting thing is they have no cross resistance. So you can switch one to. And the ASH guideline has recommended the TPO agonist over the rituximab and over the splenectomy. How it works? TPO agonists, like peptide romiplostim, it works on the receptor. You can see here, this is the receptor. It acts on the megakaryocytes. So it stimulates the JAK2 and it causes megakaryocyte proliferation. So it increases the platelets count formation. Similarly, other TPO works similarly. Now, romiplostim. Romiplostim starts from the dose 1 mcg to 10 mcg per kilo. Here you can see even up to 3 mcg per kilo, it works very well, but the 6 is the optimum. You can use it, the dose. What is the data? Data over the 6 years. They have seen the doses. This is the doses of the romiplostim. The duration and durability is here over the 6 years. They are maintaining the platelets count. Romiplostim have seen the response 80% in splenectomized patient and non-splenectomized up to 90%. And the durability is about here 40 to 60%, up to 60% non-splenectomized has the durability of the platelet response. What about other one? New avatrombopag is the response is there. Here the durable response. Data is emerging now. What about rituximab? How it works? Everybody knows rituximab is CD20, anti-CD20. So it attached to the anti-CD20 means B cell. So once it's attached, they will not release the immunoglobulin. So no immunoglobulin, no hugging with the platelets. So there is no phenomena of ITP. So this is how the mechanism. The response rate is 60%, but over the 5 years, what you see, 20% people have durable response. Very interesting thing about the rituximab. They have seen more female responder in the rituximab. And splenectomy. Now, what is the splenectomy? 60 to 80% they have response. But remember, for splenectomy, you have to 2 things in mind. Just check in the imaging. There is no accessory spleen. And laparoscopy is very important. You can do laparoscopy. The important thing is discuss with the side effect, the long-term side effect, thromboembolism, cardiovascular events, and most important thing is sepsis. There are high chances of sepsis. So the patient take also vaccination and continuous, maybe some patient need antibiotics as well. Because of this, splenectomy curative option is going down. You can see in 1991, it was 30. Now is over the 2009 is here. It's about very low number of patients they are going splenectomy. This is because of new data and new treatment options. So what are other treatment who are refractory to the other medicine? The other is like fostamatinib. This is inhibitor of spleen tyrosine kinase. The response rate is 20% is low because it was heavily treated and non-responder to anybody. So other is danazol, which is androgen hormone, shows also better response in elderly patient, and immunosuppression, azathioprine, and all these things. Now, summary of the treatment. So I made a summary we call as a SERI. SERI, S for spontaneous or steroid, 20 to 30% they go for discontinue or treatment remission. E for then A for agonist. You can use agonist, TPO agonist. That is also 20 to 30% discontinuation. Then R for rituximab. Then I for give immunoglobulin till you use other treatment of second options, which I mentioned. And then last is the splenectomy. If no response, you can go to splenectomy. This is how you can use SERI and how to treat the patient. Now, burning question of 2021. We have talked about the TPO agonist, very good. But the options are, well, now we have 2 to 3 options. Who is the best in punch? So we have to see who is the rapid responser, who have the data of long-term efficacy, who have the data of about durability, and who has the data of the discontinuation of therapy. So who is the rapid responser? You can see as compared to other azathioprine, danazol, and rituximab, or splenectomy, but the best thing is the TPO agonists, they are the best responder, rapid response. Out of the romiplostim is the best one. Efficacy. Over the 8-year data, you can see romiplostim efficacy data is very durable data. It is platelets count more than 50,000 to more than 100,000. And then avatrombopag is also 4-year data, also indicating the durability. Now, We have seen NPLET offers rapid response, and interesting thing is with the remission occurring 1/3 of the patient, about 32% remission. It's very huge. And more data which is emerging, we call as a treatment-free response, TFR, treatment-free response. Romiplostin has seen 51% as compared to the bag, which is 24%. So now, let's wrap it together, bring it all together, and we can make a guideline, initiative, goal, and specific to patient guideline. There are IC treatment algorithm. Initial treatment is steroid plus minus IVIG. And subsequent treatment is medical, robust medical is the TPO agonist or rituximab. And less robust is, as we mentioned, other therapies like MMF, azathioprine, cyclophosphamide. And surgical treatment is splenectomy. What about the ASH guideline? ASH guideline actually divided into 3 groups. Patient who are high value on achieving durable response, like TPO and splenectomy, and the patient who have long-term response like rituximab and splenectomy, and patient who avoid surgery, they have the TPO and rituximab. So let's see what the patient clear. We have to see our real world experience, A to G. We want to see we hit the patient, hurt the patient. Number one, 53-year female who has bruises all over the extremities and platelet count is 12,000. Clear-cut ITP and bleeding case. Now, A for accurate diagnosis. What we will do? The important thing is peripheral phlegm and rule out other causes, infective, autoimmune, and other things which was done. B, before beginning treatment, check the indication. Yes, there is indication. Patient is bleeding and need hospitalization. So these are 3 options you can give it. Now, choose the therapy and drug, avoiding the drug toxicity. So there are options, prednisolone and dexamethasone. So in this case, dexamethasone was given. After 2 cycles, patient have very good remission. But after 3 months, again, the platelets went down. So what is this? Relapse or refractory? By definition, it is relapse. Why? Because it occurs after initial therapy or with failure to achieve subsequent first therapy. So now, what is the option? Option are 3. Drug or surgery. So what do the guidelines say? Drug decision. So either you can go for a splenectomy or 2 to 3 TPO or rituximab. Now what algorithm of this patient? This patient actually fall in this group. She wants has high value of avoiding surgery. So she wants either TPO or rituximab. So she took also TPO, romiplostin, and what happened? After 9 months, we started to taper up 1 weekly, then 2 weekly, then we off medicine. Now over the 5 years, with durable platelet response. So it's now almost treatment-free remission. Now, this we call as a hit the disease rather than hurt the disease. Now, another case, 22-year male who has history of ITP, and he was treated with the rituximab. He also fall in which category? He actually fall in this category. He want durable response. He doesn't want to continuation of therapy. So we have 2 options, rituximab and splenectomy. Rituximab was given, didn't work. So other option is splenectomy. So what we did, we got help from, again, romiplostin and platelet. We give 2 injection of this and it went up, and surgeon was happy to remove the spleen because the platelets are 10,000. They were not happy to remove going to surgery. So this is the good response with the NPLET help, and the splenectomy one, then durable platelet response. So this is how we hit the disease. Now, third patient, 27-year lady who has EVAN syndrome. She was not accepting any treatment. On and off, she was taking steroid and IVIG. So what happened? Over the 3 years, she also developed left leg swelling, and she came in the ER, and Doppler was negative. So what we should do, we should do CT venogram, and that found she has also pulmonary embolism as well. So in this patient, it's very difficult to treat because low platelet count, and you have to give also heparin as well. So platelet count was 20,000. So what you will do, you have to continue anticoagulation and aid steroid, which was given to this patient. Now, patient improved after 6 months. We discussed with the patient what she wants. These are the options for patient. Patient doesn't want surgery, so no splenectomy. She wants TPO or rituximab. So in this case, we give rituximab. Initially, she respond, and later again it went down. And later, we give romiplastin. And what happened? Over the period 6 months, we stop romiplastin. Now she's on discontinuation therapy. She's doing good. Now, what do you think? This is hit, A to G hit of the disease. Now, fourth case. This is again a young male, 30-year, who was diagnosed ITP. Initially, he used 3 times of steroid. Then finally, he agreed he wanted to go more therapy, either rituximab or romiplastin. Initially, we gave rituximab. It worked, but again, we lost the response within 2 months. So he was given romiplastin, and you can see it went up. And after a 9 month, again, we taper off the romiplastin. Now, after this, over the 2 years, he's off therapy. So he romiplastin off therapy. So this is one example of the sustained remission in patient with ITP after romiplastin. So now, last 20 minutes, we talk sustained remission of ITP after romiplastin. We have gone through D1 to D8 diagnosis, disease, and dilemma of the treatment. We've gone through the ITP journey A to G, how to accurate diagnosis before beginning start. Think about this, careful treatment choice, and then hit or hurt. You have seen the concept. Initiation of the goal, we have seen. Romiplastin, we have seen win-win policy. Real world experience, I present 3 cases. This is our goal. And so let's ask the questions. Thank you very much. If you have any question, please put on there. I'm here happy to answer the question.